is with great honor that we present the second annual Journal of Pediatric Urology lecture to be given by Tony Macedo on long-term bladder outcomes following fetal myelomeningocoele closure. We're grateful to Jesus College, in addition to BAPU, for allowing this meeting to happen, as well as appreciative to Elsevier and the Journal Company. Tony is Professor-in-Chief at Universidad de Federal in São Paulo, in addition to President of Cacao, a pediatric urology nonprofit. Tony has trained over 30 fellows, and 8 of these have gone on to be chiefs of pediatric urology programs in Brazil. Tony is a prolific author with over 170 publications and chapters, in addition to having 5 named procedures. He's one of the associate editors of the journal, a position which he took on in 2019. In addition, he is fluent in 6 languages and plays 5 musical instruments. Not only is Tony a fantastic surgeon and great academician, he also knows how to have fun. We certainly look forward to this lecture. And Tony, why don't you go ahead and take it away?
Well, thank you very much for this opportunity. Actually, it's a pleasure and an honor for me to be here in Cambridge because, as you know, my first certificate in life was held by the Cambridge University. It was the first certificate in English. And also, it's a pleasure because I was trained in pediatric urology in Europe. So it's really has a meaning for me to be here with you in Europe and give this lecture to the JPU that I serve, initially in the scientific board reviewing papers, then as assistant editor and now associate editor since 2019. So, and the topic I'm going to discuss with you is, it resumes all my interests in pediatric urology. And it's basically related to neurogenic bladder myelomeningocoele. And the start of this talk is in 2011, when the MOMS publication, which was a randomized control study comparing prenatal and postnatal surgery for myelomeningocoele, showed advances for fetal surgery, especially in regards to the reduction of ventriculoperitoneal shunts and also improvement in motor status. And in Brazil, in our university, Federal University of São Paulo, Professor Cavalheiro had already done a few cases before the MOMS, but there was an agreement to stop until we get some results from this study. And also Professor Moron from the fetal medicine. So when the MOMS showed advances, they started right away performing fetal. They were the pioneers in Brazil, and we were fortunate to belong to this group. Just to give you an idea of the relevance of our group, this is a publication, the British Journal of Obstetrics and Gynecology from Professor Moron in 2018. And you see, at that time, he reported 237 fetal surgery procedures for myelomeningocoele. Professor Cavalheiro is also a pioneer in other areas for fetal surgery. For instance, he was the first reported on a treatment, fetal treatment of occipital encephalocele. So we had the best scenario possible. We were all in a university hospital, all chiefs in their own departments, so used to conduct research. We have this Bifta group together for more than 20 years, and this group was the precursor in Brazil. So we started having a nationwide experience as far as all patients would have to come to São Paulo to be treated, and they are very linked to us to continue follow up and see the 4 of us, Professor Cavalheiro, neurosurgeon, Professor Moron, which is a fetal medicine, Professor Alexandre Lourenço, which is a fetal orthopedics trained in Chicago, I was telling my colleague here, and myself in pediatric urology. And that's something unique. That's in my office. I have just beside me this setting for performing urodynamics. So, urodynamic study in our practice is also a natural sequence of our appointments for spina bifida. This gives us the opportunity to have homogeneous urodynamic studies in a prospective way. And if you look back, these were the papers before MOMS showing no advantage, and after MOMS, which I would like to show you. And very interestingly, in the beginning, the group from the MOMS, the urological MOMS group, this group from Poland, and this group from Switzerland, with only 8 cases, all these 3 groups were advocating benefits of surgery. And we were the solely one that were not seeing improvements in the bladder. And back in 2015, with very detailed urodynamics results, recording maximal detrusor pressure, we started reporting our data. This was the first paper for bladder behavior after the MOM study in the neurology and urodynamics. It was only an 18-patient report, which was followed by the first urological MOM study. Well, the design of the paper, of this paper, I would like to make some comments. First of all, there was no criteria for identifying risk for bladder. All patients started doing at maternity CIC, and then they were followed by various clinical providers, not a single institution, were not seen by the same institution. That means, although they were informed how they would behave, there is no homogeneity in the follow-up, also regarding to urodynamics. So their main conclusion urologically was that prenatal surgery reduced the need of CIC, but they don't present detailed urodynamic studies. Well, this paper in which we report the first 51 cases is a landmark for this population, especially because Lealda Cruz, which is my associate, and also I trained her as fellow, as post-graduation in the university. We offered this classification for bladder behavior, this categorization system that we applied every single time we see a patient, in which this is the most important group, the high-risk group, in which you have overactive bladder with detrusor contractions or leaking at a higher pressure than 40, or filling pressures above 40 centimeters of water. But we also define, and this is very important because it was not considered, if you see all the categorization system, this group of incontinent, I'm talking about leak point pressure or cystometry pressure lower than 40. And this can predict the natural history of these patients in the long setting. So these are the patients who probably will stay incontinent. And you have to consider, because we are talking about transition and other stuff here recently. And you know that the patient that leak at a lower pressure, their fate to leave diapers is to undergo a big operation. So this is also a very important and significant abnormality of the bladder. We had a group which has a very low pressure but doesn't contract, so large residual volumes, which we called the underactive bladder, and the normal. And you see from our database on urodynamics, as I show you, with first urological appointments at 5 months, mean follow-up 15 months. At that time, 26% had hydronephrosis, thick wall bladder 15%, vascular reflux 25%, and here you have the categorization distribution of this population. You see high risk, 56%, incontinent, 37%, and the other patterns, only 4.2% they are the normal bladders. And we moved on to our data, and we report when we reach 100 cases. And very interestingly, you see the distribution remained the same. High risk, 52%. Incontinent, 27%. Underactive, 5% and 14%. And that's how patients were being integrated to our prospective study. And if you look for the distribution of patients who had vascular reflux or hydronephrosis, the majority of them belong to the high-risk group. So this is a very important group to be followed. Subsequently, there were reports, other alternatives, fetoscopic surgery. This is a group from Texas who reported a 14 cases series showing 64% overactive, also similar to our data. But it was very interesting because in this manuscript, there is this comment where the MOMS trial cohort is limited by heterogeneous urologic follow-up and managing. The Federal University of São Paulo has published its single investigator prospective urologic assessments. That was a recognition for our work. And also in Brazil, we are talking, a colleague with pediatrician, I don't know where she's here, Dr. Pedreira, which was an obstetrician we trained. She's 2 years ahead of me. She's doing the fetoscopic as well. She developed a technique. And I may tell you that now, just in the city in São Paulo, we have 4 teams performing a fetal surgery, closing bladder. So these give you an idea of the amount of cases we have, and not only in São Paulo. We have several other centers performing this. Well, in regards to obstetric patterns, we look to see if prematurity plays a role in the distribution of the categorization. So we divided our group in the gestational age at birth below 34 weeks and more than 34 weeks. And very interestingly, the parameters were pretty the same. So it's also showing that it has no impact. It doesn't matter if the prematurity happens. It doesn't affect bladder behavior. Well, we were the first as well to report on long-term results. This population was presented to the fetal diagnosis, where we were the first to report on 5-year-old patients. And again, the distribution remains more or less the same, 45% high risk, almost 30% incontinent. We were already finding some surgeries necessary for this population. And if you look for continence after 5 years of birth, 12 patients, 85% were under CIC. Only 3 have no leakage, 78% on diapers, 8, that means almost 60% perform washouts, and this was our conclusion. Almost 80% have abdominal patterns. Need for surgery at this term was 4%, and this is the data that we had for continence. Well, so came out the second urological MOMS study, which was reported by Brock and Cole and Associates in 2019. So they contact the family for children older than 6 years and did an assessment, and their objectives was to record CIC and to record continence. That means CIC in or out of diapers and able to avoid devolution. But if you look in the methodology of this study, there are so many limitations. For instance, they contact the family. If you read the paper, we don't know it's a visit. They came to the institution to be seen by a doctor, or were then talked by phone. So literally, families were offered a single comprehensive study visit, or alternatively, a telephone interview with parentally reported urological outcomes. What does that mean? The father reporting if the child is voiding. Also, they were offered video dynamics, but we don't know where or when. CIC, there is not in the methodology a strict criteria for beginning CIC. It was referred to the treating physician. So it's very difficult to come to a conclusion with this methodology. And these are the data they present, but we don't know at what time urodynamics were performed. And there is no register of pressures, high pressure, bladder only, vesicle, retroviral, and very interestingly, the only comparative pattern that they shown, which was uroflow data, you look prenatal and postnatal, and there was a post-void residual. But they are comparing 19 patients in the prenatal with only 1 patient in the postnatal. Well, so they were more modest in their conclusion. Most children are in diapers, more likely to void volutiously than the postnatal, but they don't present data consistent, and they were modest in their conclusions. Urological outcomes alone should not be the sole impetus to performing uterine closure, which was very different from their first paper. So, some people were criticizing our work because we didn't have controls, but ethically, when we started doing this operation after the mom's publication, ethically we could not offer, and what happened in our institution, we could not have cases operating postnatally, just the ones that come in from referrals from other institutions treated. So what we did, we looked back for the patients under the same protocol we started in 1999. This was my fellow, João Parisi. It was his post-graduation thesis. But it was heterogeneous because postnatal, some patients come later. So we define in the group 2, the postnatal, a subgroup for patients presented in the first 12 months of age for presentation. And this paper that we published was the record of number of reviewers. There was 9 reviewers for this paper that I have to answer. So what we did, we reviewed 3 first urological examinations. We record the medical history, physical examinations, prospectively in the fetal group, as I was doing, and then I look back to see in my, retrospectively from that old population. And you see here, if you compare age at first presentation for group 1 with subgroup 3, they're almost the same, 5.1 months and 4.2 months. You have higher UTIs in the postnatal group, but it has much longer follow-up. So that's expected. But you see, hydronephrosis at presentation, bladder thickening, and vesicular reflux were very similar. And also, we had the only thing that was statistically significant in difference was the trusor overactivity was in group 1, in the fetal group, but we could not explain why. The other parameters were no statistically significant. And what we did, every assessment, we were recategorizing the patients in 3 urodynamics. This is the comparison of the 3 urodynamics among group 1 and group 2, which is the postnatal January. But when you look for this subgroup 3 and you look in the first exam, there is no difference in high risk, underactive, and also in the incontinent normal patterns. So that's what you have around time. If you see, for the high-risk population, there is a decrease in pressure when you follow them subsequently with 3 urodynamics, whereas the normal population starts to increase. And the underactive and the incontinent population remain more or less the same. This is the conclusion we got. Very interesting, because as far as we had this prospective database, we looked only in the incontinent patients to see what happens around time. And from this population, we had 25% which were incontinent from the 120 when we did this analysis. And we identified in this population 23 that had at least 2 urodynamic evaluations to see what happens to leak point pressure. And here you have the lists. 43% of patients with low DLPP, the trusor leak point pressure, have kept the incontinent pattern. If the initial LPP was below 30 centimeters of water, 70% remained with the incontinent pattern. So these are the patients we are going to operate when they reach 5, 6 years of age in terms to give them continence. And very interestingly, the group from Switzerland, which reported advantage comparing 8 cases, came back with their series. And you see here the evolution with follow-up, 6 months, 12 months. So they were reporting advantages at birth. You see there, they had 54 patients with normal bladder and 28 with neurogenic bladder dysfunction. And what you see when time started to pass, there is an increase in the green population, which is urinary tract dysfunction, and a reduction in the normal population. Although their maximal follow-up with a reasonable number of patients, it was 3 years. They had 35 followed by 3 years. But it's a very clear trend to show exactly what we were reporting in the beginning. And also, the major complications were in these groups with high-risk group. And here you see it is very similar to our data when reporting the first 100 cases. Again, our data reconfirm earlier published favorable preliminary results, but they also demonstrate that the positive effect remains limited. In other words, they are not sustainable. So where we are today, we have on follow-up prospectively 142 patients. And this prospective group, I was telling yesterday, it was like a reset in the knowledge of myelomeningocoele, because it gave us the opportunity to start from zero to know what happened with patients of myelomeningocoele. It was not possible before. So this population gave me this possibility. And so we report in the prospective follow-up of patients on high-risk pattern. Again, very similar data saying about the complications. And this is very important. What happens to high-risk patients if you give them anticholinergics and CIC? What's the expectation in terms of improvement? We're able to follow this population, and here is what you have. We follow them and reclassify them subsequently up to 8 urodynamics studies in one case. But if you consider stopping at more or less 5 urodynamic studies, you see the high risk, which was 100%, turned to be around 40%. That means there is an improvement in bladder function for high-risk patients if you give them treatment in 60%. This was obtained with a mean follow-up of 36 months, median 28 months. And very interesting, we were able to start recording what's the incidence of surgery need for neurogenic bladder when patients are followed from the beginning. At that time, we had just in this subgroup 13%. So we looked recently, this is our last publication done in the JPU last year, in which we recorded from the perspective the incidence of surgery. And that's what we have. If we have only patients over 5 years old, and if we look just for the high-risk group, the incidence of surgery, they are defined here, augmentations, vesicostomies, vesico-ureteral reflux surgery, ACEs, and sling. It was 10% overall, and 12, almost 13% for the high-risk group population. And we do it surgery differently. This is our concept, which we started in 1998, first published in 2000 in the British Journal of Urology, in which we do augmentation and we provide an outlet without the need of using the appendix. So basically, when you detubularize the island, you make a flap from the anterior surface of the intestine, move it cranially, then you can prolong the incision up to the meson, the posterior wall too, and you place it in an inverted U, make a plate, close the tube, make a reservoir, and then you do a Serros line imbrication technique described by a bow and end from Mansoura, but very similar to the Nissen procedure. You can use it as augmentation or substitution. This operation has been presented in several textbooks. I'm very proud of the middle illustration of the Heman book. If you look in the front page of the Heman and you see the middle illustration in the front page, is exactly this one here. So this was really very important in my career to have this technique. And since 1998, today we have more than 600 cases of those performed. And this procedure is straightforward because you just pull the intestine out of the body, you make the pouch or the reservoir, you just open the bladder very widely. I'll show you with more details the steps. You do with non-absorbable ProLens sutures, the imbrication. It's very important to keep it angulated. That's why we never place the stoma in the umbilicus, because we need stabilization of the tube facing downwards. So the first switch here from the dome of the reservoir, we always make a fixation in the abdominal wall to stabilize the tube and the valve mechanism against the abdominal wall. We also, because we noticed we had 10% of leakage irrespective of this valve. So there is an author from Israel, Daniel Yahya, who had this new sphincter crossing two flaps from the rectal. So we always do in midline. So it's very straightforward. And we added this to our procedure in 2008. And after that, we have less than 1% of leakage in our continent stomas and augmentations. You see, we can do it very cosmetic incision, 4 centimeters, not need any more. And we also have a different concept that we designed in 2005, inspired in the left column. It was, I remember, was the ESPU in Aarhus, and I remember, where is Luis Braga? I think he presented what they called the left Monte Malone and addressed the opportunities. I came back to Brazil, it was a consequence, because I was doing this procedure for augmenting. I say, my goodness, you don't have to open it completely, make an anastomosis, make a Monte tube and implant. So came this procedure, and you see, you do almost the same thing with a very small incision. You see, you can do everything outside with a 2 centimeters incision. You have a tube. We have recently a video for those that are interested in the Journal of Pediatric Urology video bank, so you can easily see the procedure. And that's the result that you have. And recently as well, we summarize those data in the AWA News. It was by request, so you have a summary of all this. Well, it's a hard work. It's the work of a life. It's a consequence of my backgrounds, where I trained by Professor Hohenfellner in Mainz in Germany. So what we were discussing yesterday, I'm getting old, but I lived that period where the leaders of pediatric urology were debating. It was so good to see this. And when we came back to Brazil, we have great opportunities to establish our work in the Federal University, also in this hospital, AACD, which is it's a hospital, orthopedics, hospital for spina bifida. It's like the Shriners that they have in the US, where we have a massive opportunity to go do procedures. And for sure, now I would like to address my thanks to Mr. David Frank. You see here, he's one of the leaders in pediatric urology, not only in this country. This I took from the history. He's always has been present here in this meeting. And he settled the pediatric urology in Bristol. He had been the editor, one of the editors of British Journal of Urology, so he accepted probably to pass into his arms the first time I presented my technique. I presented the ESPU in Istanbul in 1999, and then I sent for publication in 2000. And I have very vivid in my memories in ESPU in Madrid, when he came to me, Mr. David Friend, he wanted me to join the board as a scientific reviewer, asked me to suggest 2 other names from Brazilian, and asked me if I would accept that. I looked to him, I was a very young, motivated guy. I say, Mr. David Frank, would you ask someone that is starving of hunger if he accepts something to eat? And he gave a nice joke, laugh, and that's how our personal contact began. After that, it's my privilege to be part of the Journal of Pediatric Urology. And one of the things that most impressed in my career, I don't know if you have seen the video, which is in the YouTube, of Mr. Philip Runsley going to David Frank's home. They were sitting in the garden, and I think he was joined by Tony Caldamone, by other people. And you see the expression of thankfulness that Mr. David Frank had for this presentation was very impacting. I really ask you to go and have your own impression of this moment. And that's why Mr. David Frank is so beloved and respected. And that demonstration of respect done by Philip Ramsey, Tony Caldamone, I think, who else was there? Pat Malone, Pierre Morrican, represents why there is this nomination. And I feel very honored to be the second recipient of this, which is the most important recognition in my career. And so thank you very much, and I thank you all for this warm reception here. And Mr. Dave Frank, thank you very much for everything. Thank you.
So it truly is my privilege to present this medal to Tony Macedo. Why? Because he's such a close friend, he's been a close colleague for so many years, and also to share with you the reason behind this medal. So it began with the concept that the Journal of Urology, particularly the company of the Journal of Pediatric Urology, wanted to give back to the affiliated societies some token of appreciation, some token that would represent the meaningfulness of the journal and the mission of the journal in order to enhance the education of pediatric urology around the world through the affiliated societies. And so through the generosity of the journal company, this medal was indeed established. And Tony Macedo went through some of the history of the birth of the journal, but it really took a tremendous amount of courage to start the Journal of Pediatric Urology, because David Frank, along with Pierre and Philip to a certain extent as well, really went upstream with that battle. It was at a time when, as Tony mentioned, David Frank was on the editorial board, a respected member of the editorial board of the British Journal of Urology. He solicited not only the Brazilian contingent, but he went and solicited a lot of the North American contingent as well. And quite frankly, and I'll include myself in this group, he did not receive a lot of support at the time. He felt that the Journal of Urology was the voice of pediatric urology as well. They had put together a separate section just for pediatric urology, and that was all we needed. Well, that's not all we needed, because we needed some strength, and we needed someone who would put their foot out and take the risk of starting a journal in pediatric urology in order to move pediatric urology on an international level. And that's where the concept came up. Now, the medal itself is to honor David Frank, of course. And the medal has two sides, of course. The first side says 2002, Antonio Macedo, Jr., Journal of Pediatric Urology Lecturer. The second side says David Frank Medal, and it has a golden eagle on it. I'm not going to tell you the story of the golden eagle right now. I think that takes a discussion that happens in maybe the Eagle Pub would be a good place to do that some night after a few rounds of drinks to get the story behind the golden eagle itself. But that has a lot of significance in and of itself that many of you know. It's also fitting that Catherine DeVries is here, which is one of the first recipients of the Journal of Pediatric Urology Medal, the David Frank Medal from last year. And secondly, the fact that its intent was to benefit the educational mission of each of the affiliated societies, and the first society that's represented with that intent is the British Association of Pediatric Urologists. What could be a better way to start off this medal to an affiliated society? So with that introduction, I'd like to present this to Tony Macedo for the wonderful lecture that he gave today. Congratulations.
Thank you. Really great. Thank you.